The Art 2018, again here in Westminster. I'm here with Zudin Petjuri talking about nutrition. So, like a lot of other trainees out there, we don't really know much about nutrition. Frankly, a lot of us don't care, which is not exactly the situation we want to be in, particularly on intensive care where the metabolic needs of our patients are vastly different to those on the wards. Tell me, why should I, as a junior trainee, care about nutrition?
Well, I think, Tanj, you've reached the first stage of specialty medicine here. When you say most of your junior doctors don't know anything about nutrition, that's true. Neither do the treating consultants and clinicians. Okay. And neither do the experts in the field, and neither do the researchers.
So we are blind leading the blind, or
we
is
are
there...
exactly that. At the moment, to summarise where we are, we give nutrition based on guidelines. Those guidelines are based on the research that's 20 or 30 years old, sometimes 70 years old. We heard today that the Harris-Benedict equation was generated from 34 patients over 100 years ago. And our concepts of ebb and flow and management of feeding come from intensive care medicine 30 or 40 years ago. So that's how little we know about the subject. The second thing you said, most Chinese don't care. And I would say, well, that is a bit of a problem, because if you asked our patients what they care about, I don't think they really care about your peak. I think the driving pressure versus mean airway pressure, patients don't give a damn about that. Patients want to know and we know this from asking patients, when they leave intensive care, will they be the same person? When you tell them that if you're of a working age, 50% of you aren't going to return to work in 1 year. If in your 40s, 30% of you are going to need caregiver assistance to your activities of daily living. Your wife, your children are going to have to help you go to the toilet. They're going to help you feed, right? They're going to make sure you try not to wet the bed. Why? Well, it's because they lose so much muscle. If you're critically ill and multi-organ failure, you will lose between 2 and 3% of your muscle mass every day that you are critically ill. Okay? The result of that is you're wasted, you're disabled, and you can't do those things.
So how should we be feeding our patients? Because currently, certainly in the units I've worked on, you've got a nutritionist or dietitian who will come in. They will prescribe one of maybe 2 or 3 feeding regimens, and then that's it. And the issue that I have is I'm removed from that decision making.
Yep.
And secondly, if we're supposed to be delivering a patient-focused care, surely there are more than 3 types of people.
Great. So that's a great statement. Okay. The first thing to say is, well, young consultants like myself, we say this, right? And I say this a lot. You've got to ask yourself what sort of intensivist you are and what sort of intensive care team you want to work with. Do you work in a hero ICU situation where everybody is a hero? They come in and without you, the whole thing falls apart. I know how to do this. I know how to do that. Yeah, that Tanj guy, he's an A&E ICU trainee. He's got no idea how to ventilate. I know he did all the stuff yesterday. I'm just going to change all that now.
Yeah.
Okay, or would you work in a system where actually there are 170 people in this intensive care unit. We're all working together and we have one goal. Get our patients out, get them out in the best care possible. So why aren't you asking the dietitian what you prescribe? Why aren't you talking to the dietitian about the rationale behind it? That's the first question I would ask you. Because what you talk to your physiotherapist, you talk to your physiotherapist.
Yeah, we do.
So why is the dietitian different from the physiotherapist? Why is it different from the surgeon? The surgical registrar says it comes in, clear fluids on, you're going, hello, you're not getting back to theatre, you've got a perfect gut anastomosis. Oh, there's no gut anastomosis, why aren't we feeding the patient?
See, this goes back to the internal circular argument of why is ICU, why is medicine in general so siloed?
Well, yes, so we're intensive care. The best thing I would say about intensive care, so I work at the Glenfield right now. I'm moving to Bart's Health shortly. I can say the Glenfield is completely a team-based intensive care unit. Okay, we have our arguments, we have our discussions behind closed door about management, and then we move on.
Do you round together?
Yes, we round together. Okay. Sometimes we don't have enough physios and OTs and dietitians, so they wander off, but they come in, we come back and make them. Let me answer your second question, why feed them?
Yeah.
Okay, because the guidelines are full of rubbish. We don't know what they're. I can't swear on this, but they're swear-worthy.
Okay.
Our own work suggests that we can't use carbohydrates for generation of ATP. You can't use fat for generation of ATP. And the protein you give them isn't very useful because you can't generate protein homeostasis in the first 7 days critical. So why bother feeding them? It comes back to the same question I put to you about the kind of intensive care you work in.
Okay.
Right? So if you work at some stage, feeding is going to become crucial to these patients. You've got no idea when that is. This idea of early, late, top up, all that, these are arbitrary terms for research purposes. We're back on the shop floor. At some point, feeding is going to become important.
Okay.
So are you going to risk that the hero intensivist is going to work out that moment? In between everything else, complaints from the surgeons, junior doctors filling in exception reports, 23 beds, major trauma coming in.
No, you're not.
You're not going to do that,
You're
right?
not.
You're going to put it out to the team.
Yeah,
What do we know? We know from the target trial that enteral nutrition, you can give a lot of it, it's not going to harm people. Okay. We know the protein, generally speaking, isn't going to harm people. Our own work suggests in the early phases it might do.
Nitrogen-rich feeding doesn't hurt people?
Can hurt people, right? But if you look at actual practice, and this is a step away from research into clinical practice, no one gives that much protein in the first few days.
Fine.
Because we don't, as you pointed out, no one cares.
Nobody cares. Fine.
Okay, so I would feed along the guidelines. Okay, things I might do differently are I like the ESICM guidelines. Okay, because if you look at them, there is exception for clinicians to take a look at the patient and ask yourself the question: in this patient, at this point in time, could I feed them? Could I feed them and cause harm? Okay. And if you're not asking that question about every single intervention you do in intensive care, go and find another specialist. Okay. So that's one, right? The second thing I do is I don't rush to jump in with PN. Okay. So there's no evidence that early feeding in the first 7 days makes a difference, but you can do a lot of harm by jumping in.
Okay.
So all our guidelines say you can probably wait 3, 5, 7 days in front of your aspirin, SCCM, yada yada. I would take a relaxed approach for 7 days, unless I know, someone's coming in with major bowel surgery, right? They're going to need it. Have you ever worked in the unit where you've said, I want to start this person on TPN, and 15 minutes later the bag is up and it's going in?
Yeah.
Does it ever happen to you?
No.
Okay, ask all yourselves.
Yeah.
I say start TPN because I know that 2 days later it's going to happen.
Yeah.
Okay? And this is
And 2 days later it's Friday and it's not going to happen over the weekend.
Exactly. So you ask early.
Fine.
Okay?
Early.
And this is what I'm trying to say is, when it comes to these conferences, you've got to remember the shop floor is all. Okay? And the key skill is translating our nutritional knowledge at these conferences into shop floor knowledge.
Okay.
And the last thing I'd say to you is this. In the recovery phase, when they're starting to get better, every single study shows that starvation increases mortality, worsens quality of life. Okay?
So I don't have a lot of time left, but just before I go, I want to ask you a question. I'm a big believer in sedation holds.
Yep.
Big believer in sedation holds, waking patients early. However, I've met a lot of resistance from some units that I've worked on, because to do a sedation hold every day, they want to starve the patient from midnight. And then by the time 6, 7, 8 o'clock rolls round, you make a decision not to wake them up, not to extubate them, and then suddenly you've introduced a 10-hour starvation period.
Yep.
What's your thoughts?
I wouldn't understand why you would stop the feed for that.
Prevent regurg, supposedly.
But again, so I think one of the issues with nutrition, it's one of those things, actually a bit like intensive care. You can have no knowledge, offer an opinion, and that will be given the same weighting as someone with knowledge and experience.
Fine.
And so you have to show them that it doesn't make a difference. You have to engage, and that's the reality.
Okay. Thank you for speaking to me.
No,
Thank
my
you.
pleasure.